This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, senior attending here, and today we're stepping slightly outside the traditional operating room to look at the intersection of regional anesthesia and cranial nerve anatomy.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the BMJ Open, published in 2026, titled Effect of Modified Anterior Approach for Ultrasound-Guided Superior Laryngeal Nerve Block on Sore Throat After Tonsillectomy in Adults. It's a protocol for a double-blind, randomized controlled trial coming out of Sichuan University West China Hospital.
Now, Alara, some of our neurosurgery residents might hear tonsillectomy and sore throat and think this is strictly ENT or anesthesia territory. But as we often discuss, the management of the glossopharyngeal and vagus nerve branches is foundational to what we do, especially in skull base work and pain modulation. This paper focuses on the internal branch of the superior laryngeal nerve, the ISLN.
Exactly, Dr. Aris. The study addresses post-operative sore throat, or POST. It's a major clinical hurdle. The authors note that tonsillectomy is one of the most common procedures globally, with over 500,000 surgeries annually, yet POST has an incidence of 25% to 50%. This pain can persist for 2 weeks, delaying return to normal diet and activities, and in some cases, leading to emergency readmissions.
And the mechanism they describe for this pain is quite complex. It's not just a simple mucosal cut. They point to trauma to the peritonsillar mucosa, injury to the glossopharyngeal and vagus nerve fibers, and subsequent inflammation and spasm of the pharyngeal muscles. That muscle spasm causes tissue ischemia, which just intensifies the cycle of pain.
Right. And while the Prospect guidelines, the procedure-specific post-operative pain management, recommend paracetamol and NSAIDs, there's still no consensus on the optimal approach. This is where the internal branch of the superior laryngeal nerve block, or ISLNB, comes in. We know the ISLN is a branch of the vagus nerve that provides sensory innervation to the laryngeal mucosa above the vocal cords. By blocking it, we're targeting the sensory limb of that pain reflex.
Let's talk about the specific innovation here. The authors are proposing a modified anterior approach using ultrasound guidance. Alara, why is the ultrasound-guided aspect so critical for a neuroanatomical block like this?
The paper emphasizes that the US-guided modified anterior approach offers anatomical precision and reduced invasiveness compared with traditional approaches. In the past, these blocks were often done blindly based on landmarks, which increases the risk of vascular puncture or inconsistent deposition of the anesthetic. By using ultrasound, they can visualize the structures in real time.
Let's dive into the study methodology. This is a single-center, double-blind, superiority randomized control trial. What's the patient population?
They are looking at 40 adult patients scheduled for elective tonsillectomy under general anesthesia. These patients will be randomly allocated to one of two groups: the nerve block group, which receives the US-guided modified anterior ISLNB, and a blank control group.
I noticed the control group is interesting from a blinding perspective. They undergo only US scanning. This is a great way to maintain the double-blind nature, as the patient and the follow-up observers won't know if the actual injection occurred.
Exactly. Following the induction of general anesthesia, the intervention is performed. Now, for the primary outcome, they are measuring post-intensity during swallowing at 24 hours after surgery.
That's a key distinction: pain during swallowing. For our residents listening, remember that the pharyngeal movement during swallowing subjects the surgical site to constant mechanical stress, which the authors mention impairs healing and exacerbates wound pain. Measuring it at 24 hours gives a good window into the peak inflammatory phase.
They have a very robust set of secondary outcomes as well. They're looking at post at rest at that 24-hour mark, but they are also tracking pain intensity at 1 hour, 6 hours, 48 hours, and even out to post-operative day 7. They are also recording the time until the first administration of rescue analgesia and the cumulative dosage of those rescue drugs.
They're also looking at perioperative hemodynamic parameters and the incidence of perioperative complications. In any nerve block near the carotid sheath or the vagus nerve, we have to be mindful of those parameters.
One of the strengths mentioned in the protocol is that this is the first study to employ the specific modified anterior approach for post-tonsillectomy pain in adults. However, they are also very transparent about the limitations. For instance, the study does not adequately control for surgery-related confounding factors, like the specific surgical technique used by different surgeons, and it doesn't exclude confounding factors associated with dexamethasone use.
That's a fair point. Dexamethasone is often given by anesthesiologists to reduce airway edema and nausea, but it's also a potent anti-inflammatory that could mask some of the block's efficacy. Regardless, the focus on the internal branch of the superior laryngeal nerve is what makes this relevant to our hub. If we can prove that precise, ultrasound-guided modulation of these vagal branches significantly alters the postoperative pain trajectory, it opens doors for how we manage other cranial nerve-related pain syndromes.
It also highlights the anatomical dual innervation issue. The paper notes that while the glossopharyngeal nerve handles the posterior third of the tongue, pharynx, and tonsils, the internal branch of the superior laryngeal nerve is a major player in the sensory feedback loop of the larynx and deeper pharyngeal structures.
It's that neuroanatomical overlap. If you only target one, you might miss the total pain experience. Now, let's look at the ethics and dissemination. The study has ethical approval from West China Hospital, Sichuan University, and is registered with the Chinese Clinical Trial Registry.
And the trial registration number is CHI-CTR 2I500102999. They plan to publish the findings in a peer-reviewed academic journal once the trial is complete.
It's a small sample size, 40 patients, but as a protocol for a superiority trial, it's designed to see if there is a significant clinical signal. If the modified anterior approach works, it could become a standard adjunct to general anesthesia for these cases.
It's also worth noting the timing. The intervention happens after the induction of general anesthesia. This is safer for the patient and allows for precise positioning of the neck for the ultrasound probe to identify the thyrohyoid membrane and the underlying nerve path.
Right. For our students, remember the anatomy. The ISLN pierces the thyrohyoid membrane alongside the superior laryngeal artery. That's your landmark. The modified anterior approach likely optimizes the needle trajectory to avoid the vascular structures while ensuring the local anesthetic spreads effectively around the nerve branch.
The study specifically mentions that this approach offers anatomical precision and reduced invasiveness. In a region as crowded as the anterior neck, that precision is everything.
So, to summarize for our listeners, we're looking at a 2026 protocol for an RCT testing whether an ultrasound-guided block of the internal branch of the superior laryngeal nerve can reduce the 24-hour swallowing pain associated with tonsillectomy. It's a double-blind study that could refine our approach to pharyngeal pain management by targeting the vagal sensory pathways more accurately than systemic meds alone.
It will be very interesting to see the results in 2027 or 2028. If it reduces rescue analgesic consumption and improves pain satisfaction, it's a win for the patient and the healthcare system.
Absolutely. Precision medicine isn't just about genomics. It's about precision anatomy in the procedure room. Thank you, Dr. Alara, for breaking down this protocol with me.
Thank you, Dr. Aris. It's always good to see how these specialized nerve blocks are evolving.
And thank you to our listeners. Stay tuned to the Neurosurgery Hub podcast for more deep dives into the latest literature. We'll see you next time.